we have the exciting opportunity to be joined by Dr. Saeed Azoury. Dr. Azoury is a reconstructive microsurgeon at the University of Pennsylvania. He attended Eastern Virginia Medical School and completed his general surgery training at Johns Hopkins. During his time there, he also completed a surgical oncology clinical and research fellowship at the National Cancer Institute and National Institutes of Health. He subsequently did his plastic surgery residency at the University of Pennsylvania, after which he completed his microsurgery fellowship at Memorial Sloan Kettering Cancer Center. Since returning as faculty at Penn, he has been named Associate Program Director. He continues to be very active in clinical research with over 90 peer-reviewed papers and 15 book chapters, and his practice focuses on breast and general reconstructive surgery as well as body contouring. He is also, of note, a former PRS resident ambassador and led the team from 2021 and 2022. So thank you so much to Dr. Azoury for joining us today on this PRS Journal Club podcast. All right, so the next article we're going to be discussing is entitled DIEP Flap versus PAP Flap versus LAP Flap, a propensity-matched analysis of aesthetic outcomes, complications, and satisfaction by Drs. Nicholas Haddock, who is here in the audience, and Sumit Toyoda from the University of Texas Southwestern Medical Center in Dallas, Texas. As a quick reminder, this article, along with all the articles that are discussed in this podcast, can be read for free on prsjournal.com, including an archive of all the past Journal Club articles. So, to begin, autologous breast reconstruction is associated with high patient-reported satisfaction and psychosocial well-being compared to implants. The DIEP Flap is a great standard in autologous reconstruction, but over the last decade, the profunda artery perforator, or PAP flap, from the inner thigh and the lumbar artery perforator, or LAP flap, from the back have been developed as alternatives. A direct comparison of these three different options has been difficult given the overwhelming majority of autologous free flaps have been DIEP flaps. But the authors have grown their alternative flap practice and herein present outcomes of 100 matched bilateral flaps of all three options with a focus on complications, patient-reported outcomes, and aesthetic results.
So moving on to the methods of the study, this essentially was a retrospective review between 2011 and 2022 of patients who underwent LAP flaps, DIEP flaps, and PAP flaps by the two senior authors of the paper at a single institution. Patient demographics and comorbidities, including the administration of chemoradiation therapy, were collected for all patients and were standardized in between groups. The senior authors' 50 bilateral lumbar artery perforator flaps were then selected and compared to a comparable cohort of patients undergoing PAP flaps and DIEP flaps. Both donor and recipient site complications were standardized between the patients and were compared. And then in terms of aesthetic results, the patients were standardized in terms of age, BMI, Fitzpatrick skin score, in addition to overall surgical incision design. And photos were obtained for the patients at least 6 months post-operatively. And then those were administered as a survey through an online crowdsourcing site, which is Amazon Mechanical Turk, and administered to the general public.
So going into the results next, 50 patients with 100 bilateral flaps were included in each of the three groups. The average age in the DIEP, PAP, and LAP flap groups were all 51 years, and average BMI ranged from 26 to 27. 70% of all patients were white, and race did not significantly differ between the three cohorts. There were no significant differences in comorbidities or the incidence of chemoradiation between the three groups. 67% of patients underwent delayed immediate reconstruction, meaning they had placement of tissue expanders at the time of mastectomy and then had flap reconstruction at a second surgery. 14% of patients underwent immediate reconstruction, and DIEP flap patients were significantly more likely to undergo immediate reconstruction compared to the PAP flap or LAP flap groups. Average flap weight was 690 grams for DIEP flaps, 411 grams for PAP flaps, and 672 grams for the LAP flaps. In terms of complications, 33% of patients had flap-related complications, and 35% had a donor site complication. Flap loss rate ranged between 2 to 6% and did not significantly differ between the three groups. Those who had DIEP flaps had significantly higher rates of breast wounds at 22% and flap necrosis at 14%. Patients who underwent lap flaps had higher rates of donor site seromas at 20%. PAP flap patients had higher rates of donor site infection at 14% and donor site wounds at 32%. Breast Q scores were obtained at an average follow-up of 17.6 months, and the average scores ranged from 77 to 80 and were not significantly different between the three groups. The overall crowdsourcing survey results found that DIEP flaps had higher aesthetic score ratings than PAP or lap flaps at 4.3 compared to 4.0 and 4.2 respectively.
So overall, we thought that this was a very useful article from arguably the expert leaders in the country on lap and PAP flaps. It's very impressive that they have now accrued enough patients to be able to match 50 of their bilateral lap flap patients. I would have been interested to know a little bit more about what the OR times were for these flaps, understanding that a lot of the DIEP flaps were immediate reconstructions, which would obviously distort the total length of the procedure. If, when performed in a delayed immediate or delayed fashion, the operative times could be similar in the author's experienced hands, and if length of hospitalization and other systemic complications such as DVT or PE were demonstrated to be similar, the author's conclusion that these three flap types were equivalent safety profile and outcomes could have been even stronger. And although the authors did not find a statistical difference, the lap and PAP flap loss rates were reported at 6%, whereas the DIEP flap loss was at 2%. And I do think that from a patient perspective, even though it's not statistically significant, having something fail 2 times out of 100 compared to 1 out of 20 times is a big difference, especially with such a big surgery. And so the 6% loss by these authors, who are probably the leading experts in these flaps, so perhaps in less experienced hands, we may have expected this rate to be even higher. I found that the patient photos, which you can see behind me here, that they provide to be very impressive. The authors were able to get what appears to be great projection, even with the lap and PAP flaps, which are anecdotally a little flatter. And I would be curious to know what inset techniques they use to get these excellent outcomes. So, Dr. Azoury, thank you again for joining us today on this PRS Journal Club podcast. To begin, what are some of your main thoughts and takeaways from this paper?
So thank you for having me. It seems like literally just yesterday I was sitting over there at the same stage, and it's crazy how quickly time passes. And thank you to Aaron, thank you to Maddie, and the rest of the PRS crew. I think what gives me angina is probably 50 lap flaps, and to the audience, that is an extremely complex, that's as complex as it gets when it comes to autologous reconstruction. So you have to kind of take that with a grain of salt when you're looking at the outcomes. What's I think perhaps most important when considering methods of autologous reconstruction is always considering the learning curve. When you look at these results, again, as Yoshi said, done by experts in the country, when you're first starting off doing these flaps, you're not going to have the same results. And I think it's very important, as she said, to kind of counsel patients about flap loss and look at these statistics. And you can always pose it to patients, which is what I do. And I say in a recently published article, there was a 2% flap loss in abdominally based free flaps versus a 6% flap loss in PAPs and laps. The latter is more challenging for whatever reasons. And I think it's very important to quote patients those statistics just to give them kind of a sense. But it's important to also put into perspective the patient. I think that it's all about counseling, particularly preoperatively. And if you counsel a patient that doesn't really have other options, that this is probably what's best for you, they're willing to accept that flap loss rate. It's so true. And then you just say, for whatever reason, if it doesn't work, this is our plan B or our plan C. And it all goes back to the preoperative counseling. I think taking a step back, one thing I would like to see is, and the authors can certainly put this out, is a learning curve. I think that that's important, kind of looking at both operative times, complications, et cetera, as you progress through your lap and PAP flap experience. And I think for both of those, there probably is a learning curve. I think when you're considering PAP flaps, I think one of the points of discussion is how you design your skin paddle. And we published a paper in PRS Go looking at diagonal versus transverse. And I think the ultimate goal when you're considering breast reconstruction in general, as you see from these pictures, is having a fantastic aesthetic result while minimizing donor site morbidity. I think that those are the two major goals that you should have. I think when you consider both methods of designing your PAPs, which is probably the two most common designs, you could probably get a little bit more skin, a little bit more tissue perhaps when you do a diagonal PAP, but you are compromising your donor site morbidity with a pretty unsightly scar. And I tell patients that they're going to have basically a scar going down their leg. And it's really few patients who would really accept that scar and not be happy with it. Whereas if you consider a transverse PAP where it's kind of hidden in your gluteal crease, that's a beautiful aesthetic result. So those are kind of my 2 points when it comes to like the types of PAP flaps that you can think about. The other kind of thing that you should take away from this paper is complications. So it was kind of, I think the thing that is less talked about, but and perhaps underreported, are that you can have pretty significant complications from abdominally based free flap reconstruction. And some would argue that when you get a bad complication from an abdominally based free flap reconstruction, it's worse than what the bad complication is from lap or perhaps PAP. If you get an abdominal bulge from a DIEP flap, it's not fun. It's almost a nightmare. I'd rather have a flap loss than a bad abdominal bulge from a DIEP flap reconstruction. For anyone who's experienced one, I had, one of my first patients, bilateral DIEPs, had bilateral abdominal bulges, and I attempted abdominal repair reconstruction on her, and ultimately referred her to one of my colleagues. But I think that that's something that's less talked about, and a lot of people fear kind of the complications from PAPs and LAPs, or perhaps the donor site morbidity. But PAPs, you can probably milk them through any sort of dehiscence or wound complication that they get. And what the authors showed is that really the complication rate didn't really differ between those groups. In the LAP group, the authors are already looking to the future to say, what can I do to minimize donor site morbidity with the seromas? And they're offering plication and progressive tension sutures. And speaking to Dr. Haddock, that has led to some improvement for sure. So that's, to summarize everything, I think I applaud the authors. Like I said, 50 lap flaps is really a triumph. And I'd like to see a learning curve. I think that anyone considering these flaps really has to both counsel patients about the higher flap loss rate. The one last comment I'll make before I turn it back over is that particularly with lap flaps, obviously you guys have probably been involved in all the different types of flap reconstructions, but lap flaps, the pedicle is very prone to spasm. You have to do a jump graft. You have that position change, several microvascular anastomoses. All of these steps lead to perhaps increased risk of complications. So you definitely have to consider that. I think when you're thinking about operative time, it's hard to compare really only because of the position change offered from the lap and the additional microvascular anastomoses. But what's also interesting about this author group, and speaking to Dr. Haddock, is they're already looking to ways of minimizing operative time, like perhaps leaving the abdominal donor site for the jump graft open when switching the patients to a prone position. So anyways, fantastic article. Not surprised that it was published in PRS.
Thank you, Dr. Azoury, for all of those great comments. It's great to be able to discuss this paper with you here today and to actually have Dr. Haddock in the audience to also weigh in. You talked a little bit about prognostication in your comments. Can you just walk us through your general decision-making tree and thought process when you're offering autologous breast reconstruction for someone who's presenting for it?
Yeah. So one other thought I had kind of speaking on this question is looking at the geographic distribution of patients, when you compare, for instance, Dallas to Philadelphia, your patient population is probably significantly different. I can say that the amount of patients that I have seen that have a contraindication to using their abdominal donor site is probably maybe 1 out of 200. It's very infrequent that I have a patient who's had prior abdominoplasty, prior liposuction, or a contraindication to using their abdomen. And I've gotten away with autologous abdominally based free flap reconstruction even in patients with liposuction, pretty bad scarring of their abdomen or prior surgery. So what would be interesting is to look at the different patient populations geographically, like how are the patients in Dallas versus NYU versus Philadelphia, and what you're probably going to see is, and then hospital-based. Like for instance, one of the major hospitals that I practice out of, the patient population is very different from the main line of Philadelphia, where Dr. Serletti sees patients, where those patients probably have had more cosmetic abdominal surgery, which perhaps precludes the use of abdominally based free flaps. Long story short, my algorithm is typically like, if I have a patient that has abdominally based donor site, that's obviously the gold standard. I think that most plastic surgeons would probably tell you that. And I think we've come a long way in terms of minimizing donor site morbidity. Probably there's more work that needs to be done when it comes to abdominal bulges and how to kind of risk stratify the patients, that you can do something prophylactically in those patients. But that's hands down the gold standard. And frankly, in my very slim patients, it's hard to find a reason to not do implants on those patients. I think that those patients look very, very good with implants. And I typically will offer a hybrid with autologous-based reconstruction with implants before I would offer PAPs or LAPs. But that's generally my algorithm, and I think if you talk to most people, I think abdominally based free flap reconstruction is still the gold standard.
Thank you for sharing your thought process on this. As I said earlier, I thought the crowdsourcing data for aesthetic outcomes after reconstruction was very interesting in this paper. And you perform a lot of abdominally based free flap reconstruction, and I've seen some of your patients. They have excellent results aesthetically, I would say. Do you have any pearls for improving the aesthetic outcomes both at the breast and at the donor sites?
Yeah. So it's, in these cases, we're going through kind of a thought process at Penn as to how we could perhaps push forward the cosmetic outcome. Because as I talked about, when you're thinking about autologous reconstruction, it's really minimizing donor site morbidity, optimizing aesthetics. I think that you have to take the little bit of extra time at the end of the case to really push the boundary of aesthetics. And that's really challenging. We're all surgeons. We're all like innately a little impatient and a little bit like thinking about the clock and trying to get out of the operating room. And I think that obviously plication is a big step, and I do that in almost most patients. I actually was thinking the other day, I do think that there's probably, I hate to say this, but I think I'm probably going to start thinking about perhaps liposuction of the flanks. I had talked to Sean Boutros at one point, and I recognize, I think the more that I can probably do in the first stage, probably the better for revision surgery. But I think for some patients, if I can do like a quick liposuction of the flanks at that initial operation, I do get concerned about liposuction of the mid-abdomen because of the donor site complications and dehiscence. But I think that's one avenue to push it forward. I think progressive tension sutures of the midline also helps, and really just spending that extra bit of time with the abdominal closure. Because unfortunately, once you, no matter how good your results are, getting the abdominal scar low and nice, it's not really ever going to approach your best tummy tuck. So if you get an abdominal donor site dehiscence and you have an unsightly scar, it's not great. So you kind of, it's kind of a balance between how much you do at that initial operation. But I think that those are some important points: progressive tension suture, plication, perhaps considering liposuction of the flanks. The whole conversation behind the umbilicus and what you should do for that, I think, is important. I've seen a lot that look almost close to ostomies, and even in my patients, and it's like And I think spending some extra time on the umbo is incredibly important, because we've all seen those patients where afterwards you're kind of like, but also considering maybe umbilectomy in the patients and then deferring your creation of your belly button to a later stage. I think that that's very important. But you can see kind of all the steps that you can take towards thinking about this critically. And there's so much more that you can innovate and change and add. So it's pretty exciting.
Those are all excellent points. What about for inset of the flap in the breast? Do you have any specific like suture placement or techniques you think about as you're putting that in?
Yeah, so I personally, this goes back to another important concept, which is immediate versus delayed free flap reconstruction. I think, just by virtue of being at Penn, we do a lot of immediate based free flap reconstruction, which comes with its own pain. And I think that I'm slowly kind of transitioning to delayed for several reasons. I think, all the literature that shows that decreased mastectomy skin flap necrosis. But I also think by putting in a tissue expander, the tissue expander forms a beautiful breast pocket and a beautiful breast shape. And in those patients, I have to do less maneuvering of the breasts when I put it into the pocket. But personally, I think in the immediate flaps in particular, I think putting some medial sutures to really push the free tissue medially to give the patient cleavage, and making sure that and I always mark out the kind of the envelope in the pocket of the breast preoperatively to know kind of where the breasts, where the new breast tissue needs to sit. But I think importantly, my superior and my medial tacking sutures are very important. I do them on all patients. And once I define their kind of their preoperative breast border, I'm pretty happy. I do put them in a bra as soon as they leave the hospital. I think that extra support's helpful. In the patients that have like a lot of dead space in their lateral gutter, and some of our breast surgeons more than others kind of have that result, I think closing down that space too over a drain is important. And then certainly with PAPs, there's a bunch of nice articles about coning the PAP, a lot of them by the senior author, Dr. Haddock, about coning the PAP to make it look like a breast. And that's important. I think another kind of a pearl is once you do any shaping or positioning of the flap into the pocket, I'm a big fan of SPY. So, and sometimes I've spied the flap. SPY is SPY-FI angiography, where you can spy the flap and look at perfusion. But sometimes I've spied the flap, and I've noticed that perhaps a couple of my sutures has led to an area that's less perfused. I either will then take out those sutures or I'll cut that area out. But yeah, all those steps I think are useful.
Thanks so much for a great discussion so far. So one of the findings of this paper was that PAP flaps had higher rates of delayed wound healing and infection. Can you talk about some of your pearls for optimization of the donor site and reducing morbidity of the donor site in PAP flaps specifically? Yeah,
I think that, I'm general surgeon by training. And it was kind of, I'm looking at Rami, but it was kind of engraved to me tissue handling in the case and the speed of the operation. I think that you do have to be mindful of time in these cases. And obviously these surgeons are, Dr. Haddock and his partner are super fast. So that's not a concern. But if these cases take you 12 hours to 16 hours, you're going to have donor site complications, probably more than other cases. So you have to it's more time that the tissue is open, more time that it's desiccating. And if you look at it, even after a few hours, the tissue's dry. So I always pay attention to tissue handling, like in any of my cases, like minimizing retractors if possible, like constantly kind of irrigating with saline. I think that's important. There's a lot of talk about incisional vacs. There's an issue with incisional vacs, particularly with PAP flaps. When you're doing that operation, those patients usually don't want to get up and start walking right away. And if you do incisional vacs, it also kind of hinders that. I think that there's probably more research on that needs to happen to look at, is it really beneficial to do it or not do it? I like the Aquacel AG dressings. I don't know how much that actually makes a difference or not, but the patients, I do think that part of the benefit of an incisional vac is just that no one touches the wound. No one looks at it. The patients don't manipulate it. Their clothes don't rub on it. The nice thing about the silver impregnated Aquacel dressings is you can leave it on for 5 or 7 days and no one's touching the wound. So I think that minimizing your operative time, being aware of retraction intraoperatively, irrigating the tissue, and then paying some attention to your dressing care postoperatively helps wrapping the patients. But I don't think that an incisional vac on the PAP flap is probably the way to go. I don't know if it's necessary, and I think it probably will prevent a patient from really getting up and ambulating postoperatively.
Fantastic. Thank you to everyone up here for the great discussion so far. Now we'd like to open it up to comments and questions from the audience. If anyone has any, there's a mic in the middle.
Hi, thank you so much for the discussion. I really appreciate that you talked about the donor side morbidity in DIEP. I know this is not talked about in the paper, but I was wondering if you can comment on SIEA breast reconstruction where you still use the abdominal tissue and you have easier surgical access to the vessel, possibly less surgical time and possibly no abdominal morbidity, and also possibly, reducing the likelihood of even doing a umbilicoplasty.
Yeah, no, you're absolutely right. I think that unfortunately it's not an option for a lot of patients, but there is some talk by Robert Allen Sr. about doing delayed SIEAs on patients. And I was, as a fellow, we did a couple of delayed and we did a couple of delayed circumflex. Unfortunately, it's just not an option for all patients, but if it is an option, I'll jump to it because I totally agree with you. And I think the reason being is that I think the bad complications from abdominally based free flap reconstruction, there's not enough emphasis on how bad they can be. But everyone talks about the skin of a PAP flap or, the donor side of a lap flap. But the bad complications from abdominally based free flap reconstruction are bad. And so if an SIEA is an option, I'll 100% use it. The artery, to me, just has to be pulsatile and greater than 1 millimeter.
Right.
And I care more about the vein.
Gotcha.
But yeah.
Thank you.
Yeah. Any comments from Dr. Haddock?
Sure. It was great. Honored to have our paper selected. And great I was able to be here and appreciate the very flattery discussion. I think a couple of the points that were brought up, I'll try and address. Operative time. PAPs are probably the fastest, regardless of delayed immediate or immediate. I think PAPs can go pretty quickly. Deeps would probably be number 2. And then lumbars, as was said, there's no way to make them faster than the other two just because you have at least one flip. We have, in the effort of making them a little bit faster, started prone some and harvest both flaps and then flip and do things. But you can only do that in a very select situation. You have to be pretty confident that your rib's going to go well and the jump grafts are going to come out quickly. But I think that we operate in a pretty efficient system, so I think that that's probably how it will always be. I don't know that we can make it faster than the others. Learning curve, absolutely no question. Honestly, what you're seeing in this group is our first 100 PAPs, more or less, right? We've now done 265. So we have a 6% flap failure rate with lumbars in this group. Our current flap failure rate is 3%. So there's no question there's a learning curve. I also think that early on, in that same sense, we revised a lot of vessels. And I think we spoke about this because there's a fascia that goes around the lumbar pedicle. And if you don't take that fascia off well, then you just don't get reperfusion. So you really have to open that up to get reperfusion. So our revision rate is very high globally in lumbars, but that's also coming down. I agree 100% PAP conversation. The problem with PAPs is they all have not they all, but it's a high rate of wound complications. And in this paper, I think we did break it up into major and minor, which is important. And I think a lot of people try and just talk about major complications and just discount the minor. But when you start thinking about an incision on the back of your thigh, it doesn't matter if it's, I mean, it matters if it's a major versus minor, but if it's a little separation or a little scab that doesn't require any direct care, it's still a big nuisance to the patient. And so you have to really counsel the patients in that. It's not just the return to OR or wound vac complications. It's the minor ones matter too. So I think the 30% includes minor. It is lower for what we call real complications. But in counseling patients, you have to be able to present that. And that's why we do it this way in the paper. This is kind of a patient-focused for conversation. You know, these things are a little more boutique. They're a little bit more challenging. There might be a little bit more complications in specific ways, not globally. But I think that kind of plays into the conversation with the patients. I always do horizontal for PAPs, and it's exactly what you said. I think it's the counseling. I tell them, would you rather have a great result at a year or have a little bit easier post-op recovery? And I think that with the horizontal, you get a better result at a year. We've started doing more and more of these crowdsourcing. I mean, we try and standardize aesthetic outcomes, right? We can't. And it's really hard in general. Someone that I think may have a great result, someone else may think they don't. So this is kind of the best tool we have. You know, in the past, we would get like 5 residents and say, hey, score these people and count that, and then get 5 attendings and have them score it and count that. It's not really valid, right? So you get 1,000 people that are paid a half a penny per click, but they do a bunch of these and they give you output. And so we've done a handful of these crowdsourced things. I'd love to have better ways to really look at aesthetics. That's the one area that's really hard to study, and it's in the eye of the beholder. It's lumbars. Some people you hollow out the back and then it almost gives you a buttock augmentation look. Some people love that look. Some people don't. There are certainly different flavors in that sense. But it was nice to put this together. Appreciate the conversation, discussion. It was great.
So I have one question for you. One thing that I think would be interesting to kind of publish in the future is, like, there's a lot of papers about when the abdominally based free flap reconstruction goes wrong and you have to take that patient back to the operating room. And most of the time I feel like we kind of have a good sense of if we can salvage those patients. And intraoperatively there's an algorithm, TPA, vein graft, whatever you have to do. With a lap flap, if you're taking them back to the operating room, what's going through your head in terms of what are the things I need to do? Is this a patient that I think I'm going to be able to salvage? And what do you kind of like get ready mentally for in order to enact? Because I think that would be a good paper out of your group just for people who are doing these flaps.
Yeah, it's a great point. I think that the lumbar, you've got more anastomosis. You've got the jump graft versus the flap. So you have to have an idea of where is the problem. And you may not know until you get in there. But if you're going to go back, you really have to, as with all flap takebacks, let's say you have a failure, what is your next step, right? Is this can we put an implant in and call it a day? Which honestly with lumbars is actually, and that's kind of where this paper showed exactly what we thought it would show. Lumbars look great. They look more like an implant reconstruction, but it's natural tissue. So, we have a flap failure, and, I'll tell them, well, we can put an implant in, it's probably going to match just fine. The other thing that lumbars hold up better, I think, long term. So I think that, I'll answer your question, but I think that is a reasonable thing to talk with in counseling patients. The other thing that's real important in those situations to counsel patients is, we may need another jump graft, right? And so what does that mean? The 2 other areas that we have taken jump grafts from is the lateral, the descending, the circumflex, right? And then thoracodorsal. Now, if this is a situation where you need the latissimus, then you don't want to take your TD on the same side. But let's assume it's a bilateral and your other flap is fine. You can potentially take it from the other side. So you have to think through all of those and talk with the patient about it. The incision for, it's easy when you're doing an ALT to identify those blood vessels, but generally an ALT is not a 4 or 5 centimeter incision. It's a pretty long incision in the thigh. If you think about it in your head, it's a pretty deep hole to get into to get those blood vessels out, and there is significant morbidity to that. We accept it when we're doing an ALT, but when you're doing breast recon and you're at a salvage position, you might lose this flap You have to really think, how likely are we going to save this? Is it worth going there and getting those vessels out?
Yeah.
The vessels are great, but if the flap, if you think you've got clot in the flap, et cetera, then you may not be worth it to try and salvage, and then you come up with a plan B.
Yeah. Yeah, I think that would be a nice paper out of you guys, just to see, like, what, out of the patients that failed, what did you do in the operating room, and salvage rate, et cetera. I think that would be helpful.
I'll give one other kind of unique thing that we have done for DIEP failures, and it's only when we think it's a perforator-related issue. We've actually done immediate lapse with the jump graft still there, which is a little bit aggressive, but we probably have like one or two of those, not a large volume. But if someone's committed to autologous, you already have the jump graft there. If that's not where the problem is for a DIEP, like there's potentially damage to a perforator, then you can do that. And we've done that.
Yeah. Well, thank you. I think that this paper kind of brings to light that as a plastic surgeon, you can probably convince your patients whatever you want them to get, potentially. Like, there's some patients that come in wanting certain things, like, I have to have autologous reconstruction. I want implant-based reconstruction because my friend had an augmentation and she looks fantastic. But as a surgeon, you can probably, if you're afraid of doing free flaps, you can probably push them towards the implants. But there's so much benefit to autologous reconstruction, which is probably why the senior authors are pushing these boundaries. And literally, when the patient gets beyond that first year, they don't have to worry about implants ever. I mean, they don't have to worry about infection. And that's really the beauty of autologous-based reconstruction. So I think papers like this kind of push the envelope and get us thinking about other flaps that we could potentially use. So I applaud the authors.
Thank you so much. This was such a great discussion with Dr. Azoury, Dr. Haddock, and everyone. And with that, I guess we'll end this live journal club. So thank you, everyone, for coming, for stopping by Sunday morning. And don't forget to check it out on the podcast as well. Thank you.
Thank you, guys.